Ladies and gentlemen, welcome to this session on data. Love your data, in fact, so it's going to be a fantastic session, I am sure. We have got three excellent speakers again. We have got Leigh, Chief Executive at St. Margaret's Hospice in Somerset, Dr. Katherine Sleeman, Clinical Lecturer in Palliative Medicine at the Cicely Saunders Institute, and Professor Mike Bennett from St. Gemma's and also Professor of Palliative Medicine at the University of Leeds. Anne will highlight the experiences and benefits at St. Margaret's Hospice of capturing and sharing real-time data. And Katherine will present her findings on the use of routine available data to influence service development. And Mike will consider the impact of collating citywide data in Leeds on how long individuals are involved with palliative care services and how data of this type will illustrate the impact of inequalities in access to end-of-life care. As we have been doing throughout all these sessions, we'll do all three of the talks and then we'll have questions at the end. So, Anne.
Thank you. Well, good morning, everybody. I've come from Somerset. St. Margaret's is in its 35th year, and we serve a population of about 500,000 people. We've got 360 staff, about 1,200 volunteers. We have 2 inpatient units, day hospice services, a 7-day-a-week community service in the east and west of our county, 24-hour admissions, centralised referral centre, and an advice line. And I thought it would be quite useful to put into context that we've only got one CCG, and that contract is worth about £2.4 million. So we have to raise a further £5 million each year for the care that we deliver. And we do that with a variety of different things, and I'm not going to go into that in this presentation. What I want to share with you is nothing really remarkable. I'm sure that you are all doing the things that I'm going to talk about. But I'm going to share you our journey. And on that journey, some of the things that perhaps have been quite illuminating in the way that we previously had gathered our data. We use Crosscare, HR Select, DonorFlex and Sage, all of which help us to keep a tab of what's going on within the organisation. And essentially what was happening was that St. Margaret's was increasing the amount of data required from commissioners and our regulators, and what really was happening was that we had a plethora of data. We were in data paralysis. We simply couldn't actually accommodate all the data. We had far too much paper, large volumes of it. And at the very heart of that, clinicians themselves were collating all this information and sending it to the commissioners and to the regulators and to our trust boards, but actually weren't using the data themselves to actually influence the strategic direction that they wanted to go in. Our quest for data actually really started about 2 years ago, and it started simply because we wanted to actually simplify the systems that we got in place, to reduce the duplication of effort, to reduce the risks, and to actually really reduce the cost. And staggeringly, we were spending in excess of £50,000 on paper. So the deal was, at the time, my chief executive said to me, if you can reduce the paper, Anne, you can have the 50k and you can invest it in service development. So the clinical team were very excited and animated about that. So this very short presentation is just sharing you our experiences, essentially first looking at the data that we've actually collated in relation to patient care, secondly into looking at the way that we actually manage our evidence for the CQC requirements. Thirdly, in relation to how we've actually started to use data in terms of our HR management. And finally, actually how the new GIS, the Geographical Informatics Systems, are actually helping us start to look at how we might redesign our service provision. I'm going to show you a very short, quick video, which is how we really started. It's a video I expect you've seen. It's on YouTube. It's really about the paperless NHS. And it really was starting to actually get some buy-in from our clinicians and our teams about some of the frustrations that we all experience when patients have to repeat and tell their story hundreds of times. For clarity, for us, real-time data was about the here and now, about having data that was robust and accurate and at your fingertips. Systems that would allow us to have data input and to produce information within milliseconds so that we could use that information immediately. So here we go.
Diabetes, and then I had to go into hospital urgently. Arthritis, diabetes, and then I had to go into hospital urgently. Arthritis. It's brilliant. It's all here. Everything I told my GP, and all the team can see it. I don't have to repeat myself.
So, the real-time data enabled us, we introduced cross-care, we synchronized all of our notes across all sites into the community, like many of you. And what we started to do, because it's a bespoke system, started to actually incorporate clinical audit activity within those cross-care notes. And that was because we were doing some benchmarking exercises with the South West informatics team, essentially looking at the numbers of falls per 1,000 bed days, the numbers of medical incidents and accidents. And what was really frightening was the fact that actually a lot of the benchmarking information, we thought we were at the top of the league table. We thought we were really doing well. We'd collected the information, which was done retrospectively prior to introducing the audit activity. And to our horror, when it actually became real time, we dropped down to the bottom of the league table. And it was a very sobering moment. In fact, we were really worried about it. The teams went out into the community, to other hospices, to actually work out what we were doing wrong. And as a result of that, we had to make massive changes to some of our equipment, the way that we were actually treating and looking after our patients. We introduced tissue viability teams and nurses, sent them out to get the training, and gradually, over the 2 years, we're now at the top of the table again. But I think that was a real indicator to all of us how important having the real-time data was. Now, lots of evidence suggests in the literature that real-time data does help improve patient care. There's no doubt about it that from our experience, it does reduce the patient's safety issues if you're actually on top of it on a day-to-day basis. So as those pressure ulcers, as those incidents occur, you know about them straight away as a lead nurse or as a staff nurse as well. So you can actually do something about it immediately. And also, it reduced the need for our teams to spend endless amounts of time trying to collate the information. They then spent the time on actually solving the problems. Similarly, when we started to look at it, we also realised that actually we had a huge issue in terms of the complexity of patients' needs. And as a result, we introduced a high dependency tool to actually start to actually look at the incidence and how many staff we needed at any one time and the complexity of need. And I'll show you some of those slides in a moment. There was no doubt about it that when we looked at the costs of some of the incidents in terms of time management, there were significant improvements in the amount of cost savings that we were employing. And we did some cost analysis too. And just to put that into the picture, although we were saving the 50k on the paper, we also saved 25k on the time elements associated with trying to capture the data. That was purely based on a time and motion study. It definitely improved quality and staff morale. People actually really felt that they, for the first time, were using data and it was meaningful for them. And they felt that we were using it in a much more efficient and effective way. And it also gave much more clarity and transparency because people really believed in the data. Everything coming from the cross-care notes was linked in onto our incident and accident reporting. So our team lead, who was in charge of all governance, knew instantaneously when something was arriving at her workstation, and she could actually support the team immediately. And that included also patient complaints. And although we only had 4 formal complaints each year, what did become apparent were all the little things, all the things that people might comment on. Staff felt much more comfortable about reporting, and we started to actually see an increase in reporting too. It gave us much more of a graphical view of the data. And when I show you the maps in a moment, of the GIS maps, you'll be able to see how we actually started to understand where, from a postcode perspective, linked into the cross-care database, exactly where our activity was, certainly in the hubs, how far clinical teams were actually having to travel, how they could make their journey times easier. And amazingly, all this software was completely free. So really, having this real-time data improved our CQC evidence. And as I said, it was believable. It really energised and motivated. We were able to support the productive ward programmes that we had in place. And we started to actually, as a result of the work we were doing with high dependency, stop temporary staffing initiatives. I, as the clinical director at the time, was able to convince the board that actually having a bank system wasn't as effective as having full-time complement of staff. And also, it actually meant that all of our I Want Great Care information and everything else was coming into one place, on one sheet of paper. And we now have a dashboard which is just on one sheet. It isn't, I brought paper today, I hasten to add, but this is available to each person in the organisation on their laptops, on their desktops at any one time. We also started to be able to demonstrate from an evidence perspective, looking back at the data retrospectively and prospectively, that all the recommendations that were coming through on a national level for staffing levels, we were adhering to them. We had concrete evidence for the CQC compliance. And for 2 consecutive years, we were very fortunate in getting 100% compliance. And we were able to demonstrate the lessons learned and the strengths associated with continuous improvements. And it gave us this amazing organisational memory. We were much more confident in the data that we were collecting, and so were the commissioners. So really, when we got to the CQC situation, we were able to put all the evidence together and all onto one sheet. So we were looking at life backwards, in other words, what we were able to collect, and all the data was there, the organisational memory, but we were able to use the data going forward to fix the problems. So this is just one sheet, just a spreadsheet that actually feeds in all of the information now on one sheet associated with all the evidence that we needed to collate for CQC. We built it ourselves. It's nothing special, and I'm very happy to share it with you if anybody wants it. It means that actually it's linked in, so each of the activities, you just basically, if you're left and you're the only person there and you're facing that inspection for an unannounced inspection, you know with confidence that you are going to be able to show the data straight away. It also became a live working tool in terms of where we knew we got evidence and where we hadn't got evidence. And that's been very, very comforting. So as soon as you click onto a link, it takes you into the intranet, and you can see exactly where you need to go to be able to explain to the assessors. And when we were assessed, we were able to leave the CQC teams with the evidence, and they could actually manipulate the data as well themselves, which was fantastic. But what really was apparent on our dashboards with all the information was that we really were paying lip service to our data for HR. We didn't at the time have a data sheet, if you like, a dashboard for our clinical workforce. And our data for HR wasn't particularly reliable. We didn't really have a sense of the total numbers of sickness absences in one place. Across the organisation, teams had an organisational-wide dashboard, but they didn't actually have all the information on one sheet of paper. So again, we started to recognise that we really needed to understand the health of our organisation. We'd been very reliant on simply using the national surveys for staffing, but actually we wanted to be able to capture the numbers of leavers, returners, the number of vacancies, all of that information, and collate that at the same time as looking at the high dependency levels, making sure that staffing levels were right, and also checking to make sure that quality wasn't dipping. So as you can see on this particular sheet, probably can't see it particularly clearly, but it demonstrated that we had a very few number of starters, a large number of leavers, and that at a time was pretty concerning. It meant that we were able to flexibly move our teams from the community with justification. People could actually see it. They believed it. It wasn't anecdotal. And people started to help themselves within the organisation. Clinical team leads started to share the data between themselves so that the tensions weren't there. They could see that one particular department was struggling. They would move those clinical teams across. Similarly, we were able to look at our turnover and plan for the forthcoming year and increase our staffing levels and justify that against our bank and agency expenditure. And we also started to look at the workforce, the ageing workforce profile. And now we've started to actually introduce preceptorships and staff earlier on in their careers into our clinical teams. That's because at the time of this slide, over a year ago now, 56% of our workforce were actually over the age of 50, which was quite a concern. Now that figure's dropped to 42%, simply by looking at different methods of actually attracting people in. We started to benchmark our sickness levels and compare ourselves against the NHS, and also look at the dependency levels as well. So now we have a clinical balanced score sheet with all of our activity, the one that I was throwing up in the air, which actually also looks at the turnover of staff, the number of vacancies, what the sickness levels are like on a day-to-day basis. And we have a dependency tool which we have now validated and with the university, which means that in the past we had pieces of paper, things written on boards, but now the nurse managers who are on call know exactly how many staff they've got in, but crucially what the dependency levels are, and we can flex up and use standby staff to actually help support clinical activity. So we're able to actually now look at the retrospective data, looking back, and actually work out when our peaks and troughs are going to be. And as a result, we've increased the numbers of staff on over certain periods of time of the year, which were quite unexpected. They weren't actually in the winter. Some of the periods of time were actually in the summer. So what's next for us? Well, at St Margaret's, we're now looking at that data and looking at how we can actually introduce our GIS systems. We're now able, with Crosscare, to actually plot onto a geographical database where all of our patient activity is. We can see where the hubs of activity are, the clusters, where we should be having those hubs, especially in areas of social deprivation, which are at the top end of the Somerset borders. We're able to look to see where the calls come through from the advice line and just how far in terms of planning our rapid response teams need to go and how far those distances are. We're able to actually influence the way that domiciliary provision and care is better coordinated across in Somerset too, and fundamentally just how far our day patients need to go. And we've now introduced hubs across the geographical patch. Interestingly, we're just going through a Fit for the Future process where we're starting to actually work out whether or not we do need 2 inpatient units. Those 2 inpatient units cost us 2.4 million and they represent only 6% of our activity. So the challenge that we now face is where do we place our inpatient activity? Or do we have one at all? Do we actually utilise the 13 community hospitals across Somerset and share out our service of resource into those localities? And similarly with our outpatient activity. The wonderful thing about the GIS mapping is that you can use it with the public health information and you can see where those hotspots are. So we're now looking at all of the long-term conditions and starting to be able to work out and predict where our service resource needs to be, more heavily situated in the areas which are red and less so in the others. And that's it.
Thank you, Anne. And now Katherine.
Thank you very much. So Anne has spoken of the importance of our data at a local level. What I would like to do is switch lens and talk in more general terms about how we can use routinely collected data at a national level sometimes, to understand and improve end-of-life care. So I'm going to be using this term routine data a lot, and I thought it would be useful to start off by explaining exactly what I mean by that. Routine data is data which is generated for clinical and administrative processes, as opposed to data which is generated specifically for the purposes of research. The term routine data encompasses many things. If we're thinking about healthcare, it can be useful to consider routine data on the basis of the level at which it's collected and made available. So this is a diagram made by my colleague Joanna Davis. You can see that there are 3 potential levels to collect and report routine data at. At its most simple, down at the bottom, we might get information from our area. So we might know that, for example, X% of people in our local area die at home. We can collect routine data at the service level. So, for example, how many people seen by our local community palliative care team achieve a home death. And of course, going to the top of this inverted triangle, we can collect information at a person or individual level. That individual, where did they die? There are several reasons why routine data presents an attractive possibility when we're thinking about understanding palliative and end-of-life care. The main reason is that the data already exist. They are there already, and so we don't have the problems associated with collecting new data, new primary data, in a patient population who are deteriorating and dying. Routine data analysis is relatively cheap, it's efficient, and it can be done at scale, often at a whole population level. If we're thinking about palliative care, there are many sources of routine data which are potentially useful to us. But the source which we have used most, I think most people will be familiar with, is mortality data or death certificate data. So this is a photograph of one of the original London bills of mortality. These came about in the 16th century in response to an urgent public health need to understand patterns of death associated with the plague. Fast forward 500 years, This is what a modern-day UK death certificate looks like. So it's less pretty, definitely less ornate, but it fulfills almost exactly the same purpose. And the variables contained within death data are exactly the things you would expect: patient's name, age, date of death. In fact, the most prominent section of the death certificate is in the middle, and it's devoted to the cause of death. Although it might seem that interpreting information about cause of death is quite straightforward, actually it can be surprisingly complex, and I want to spend a minute explaining this. In our society, particularly in an age of aging and multimorbidity, more than one thing often contributes to a person's death. And for the past 20 years in the UK, mortality data have included information on the underlying cause of death, as well as information on other conditions which contributed to death but didn't directly cause it. So just to give a made-up example, here's a patient who died from a pulmonary embolus. So the reason that their heart stopped beating was a big blood clot on their lungs. But the reason, or their predisposition to a pulmonary embolus, was because they had metastatic breast cancer. So in this patient, breast cancer is their underlying cause of death. In addition, this patient had dementia, which was thought of sufficient severity to contribute to their death, but not to directly cause it. And so dementia is called a mention, or a contributory cause. So we've been using death certificate data to inform palliative care for about 50 years. And of course, the variable which has most interested us has been place of death. Now, I'm not going to dwell on why I think place of death is important. I think it is, and for three broad reasons. The first, and the one I think people are most familiar with, is individual preferences. We know that most people want to die at home, and most people don't. But place of death is also important at the service and population level, for example, for health provision planning, and potentially even for assessing the impact of policies which aim to improve the number of people or increase the number of people dying at home. For all of these three things, but especially for the latter two, what is essential is not just knowing where people die, but understanding how the pattern of where they die has changed over time. Well, I was interested in looking at how place of death in dementia has changed in England. Dementia has been cited by the World Health Organization as a public health priority, and we know that hospitalization of people with severe dementia can be profoundly deleterious, with patients having worsening confusion and worsening pressure sores. We also knew from the work of Dirk Hoetekeer from Luc Delien's lab that England has one of the highest rates of hospital death in dementia in Europe. And I was interested in knowing how that high rate of hospital death has changed over time, and in particular, how it changed over the time that the National End-of-Life Care Programme was active. So at the Cicely Saunders Institute, in collaboration with Public Health England and the Office for National Statistics, we've been running a project called Project Guide Care. Guide Care aims to examine the geographical and temporal trends in place of death using whole population mortality data. So I was interested in dementia. I extracted from our very large data set all deaths where dementia was mentioned, anywhere on the death certificate in England over a 10-year period. I included data on just under 400,000 deaths. Most people were women, and the mean age was 86. Over the time period, the proportion of deaths in England where dementia was mentioned increased. In fact, it almost doubled, from about 6.6% of all deaths in 2001 to 12% of all deaths in 2010. Dementia was the underlying cause of death in fewer than half of cases, so most people died from something else, but with dementia. For example, in about 5% of cases, the patient died from cancer, but with dementia mentioned. So where did they die? Well, the vast majority of people in England with dementia die in institutions. They die in care homes and in hospitals, about 95% overall. Now, what's quite encouraging from this trend is that the trend towards increasing hospitalisation, hospital deaths in dementia, appeared to reverse such that from about 2006, hospital deaths went down and reciprocally care home deaths started going up. It is intriguing to speculate that the reason for this shift may have been to do with the National End-of-Life Care Programme, which was active at around the same time. But a really important thing to note is that this sort of observational data actually can't tell us why shifts occurred, just that they did. What we can get information on is the factors necessary to sustain this shift. In a multivariable analysis, we found that the single most important factor that determined whether patients died in care homes rather than hospitals was where they lived. If patients lived in an area best served by care home beds, they had half the likelihood of dying in a hospital or twice the likelihood of dying in a care home compared to people who lived in areas with very few care home beds. You have to look a rather depressingly long way down this graph in order to get any information about home and hospice deaths in dementia. They accounted for less than 5% of deaths overall. And in a separate, though similar, multivariable model looking at the factors associated with dying at home or in a hospice compared to in a hospital, we found this time it wasn't where you lived, but a personal characteristic that put you in that home and hospice group. It was having cancer. So that 5% of patients who died from cancer, but with dementia, were almost twice as likely to die at home or in a hospice compared to people who just had dementia. Mortality data have been very valuable to us in palliative care and have given us a great wealth of information. But I think it's really important to understand the limitations of the data a bit more. So what I would like to do now is just unpick some of the limitations, because unless we understand those, we can't use the data to make the most difference for our patients. I said right at the beginning that one of the great advantages of using routine data like mortality data is that we have access to the whole population, so there are potentially fewer issues with generalizability. But a really important question to ask is, the whole population of what? In fact, which population have I just presented data to you on? Ideally, the answer would be people who died with dementia in England over a 10-year period. But we know that mortality data are only as good as the person who writes on the death certificate, and very often that person is the most junior doctor around. Incomplete and inaccurate death certification is a major limitation of mortality data, and one which I thought probably particularly affected dementia. So what do we know about how well dementia is certified on death certificates? Well, the answer is very little. This is a BBC News article from last year that tells us that dementia is the leading cause of death for women, having overtaken cancer and heart disease as a cause of death. And that's completely in line with the data I showed you before, where the number of death certificates, the proportion of death certificates in England containing a mention of dementia, doubled over 10 years. But what we don't know is whether this increase reflects an increase in the true prevalence of dementia, whether it reflects improved detection, or whether it simply reflects improved certification of dementia on death certificates. So with colleagues at the Institute of Psychiatry at King's, Guyon Pereira and Rob Stewart, I have been interested in answering this question: how often is clinically diagnosed dementia recorded on death certificates? We used a database called CRIS. CRIS stands for Clinical Record Interactive Search. It's a clinical database. It includes the clinical records of all patients seen at the South London and Maudsley Trust, which is a specialist psychiatric trust. But CRIS isn't just a clinical database. It was set up for research and in particular to facilitate linkage of those clinical records with other sources of routine data. So from CRIS, I identified everyone who had a clinical diagnosis of dementia, either in the free text or coded. For people who had a clinical diagnosis of dementia within the CRIS database, we then linked their records at an individual level to ONS mortality data to determine who had died. So it's this population in blue who were the focus of our study, and we had 2 questions. First of all, for these people who had dementia and died, was dementia written on their death certificate? And secondly, what were the things that made dementia more likely to be written on their death certificate? This is new data, it's unpublished, and I would prefer if it wasn't tweeted. So we found that over the 7-year study period, which was the data we had available, just over 7,500 people with a clinical diagnosis of dementia died. And the place of death was very similar to the national picture. Most people died in hospitals or care homes. Of those 7,500 people who died, just 41% had dementia written on their death certificate. We looked at the factors associated with having it written, and we found that some of the things were as you would expect. So people who were older, people who were more cognitively impaired, they were more likely to have dementia written. We also found that the odds of having dementia certified increased by about 80% with each year of the study period, suggesting that a lot of the increase in prevalence of dementia mortality seen through mortality data may simply be because we're getting better at writing it down. And interestingly, for palliative care, we found that the most important factor associated with certification of dementia was where you died. So people who died in care homes were more likely to have it certified than people who died at home. Now, this was a very simple study, but I think it has 2 quite important implications. One is an implication for public health because we need to know what we're counting. The second is an implication for palliative care because if certification varies according to where you die, then that makes interpreting information about place of death much more complex and less straightforward. So we need to understand the limitations of the data that we use, but I also think that we need to use the data that we have. Routine data are often criticised for being very broad but very shallow. So we have a very large N, but few variables available for analysis. And what that means is that we can often find all sorts of significant differences in our data, but it's very difficult to understand what those differences truly mean. But routine data don't have to be shallow. Over the past decade, as everyone knows, there's been a very strong policy focus on the place of death. I think we are all aware that place of death is an imperfect proxy for quality of death, and probably the reason for that strong policy focus is because it's extremely easy to measure. Other aspects of the quality of a death far less easy at a population level. A couple of years ago, Joan Tino published a study which asked quite a simple question: is end-of-life care becoming more aggressive? She used routinely collected insurance data from the USA, and she looked at 3 time periods over the course of a decade. She found, as we have, that in the United States, acute hospital deaths are becoming less common. Hooray. But death in hospital wasn't the only outcome she had available to look at, and she looked at other indicators of potentially aggressive end-of-life care, which showed an entirely different story. She found that over the course of that decade, ICU use in the last month of life went up. Healthcare transitions in the last 3 months of life and the last 3 days of life also went up. Now, we don't know, or at least I don't know, whether there is a similar picture happening in the UK. We don't yet have this sort of insurance data in order to answer that question. But actually, we don't need it because we have available different sources of routine data, which if we link them and put them together, will enable us to answer questions like this. By linking at the individual level different sources of routine data like ONS data and hospital episodes data, we have the potential to build a resource which is both wide and deep. And we don't have to stop at place of death as our outcome. So this is a paper published last year in the BMJ by a Swedish group. They linked 5 sources of routinely collected healthcare data to answer a really important question for our patient population about the safety of drugs. So we need to understand the limitations of the data we use, and we need to use the data we have in smarter ways. But we also need to collect data we need where that data simply doesn't exist at a national level. Earlier this year, we published a paper looking at the changing demographics of inpatient hospice deaths. It was part of Project Guide Care, so we identified every patient who died in a hospice over a 20-year period, and we wanted to know who those patients were in very broad categories. Just under 450,000 patients were included over those 20 years. It probably won't surprise you to see that the vast majority of those patients had cancer. 95% of hospice deaths over the last 20 years are in people with cancer. What did surprise us, in fact, what shocked me, is that we found that the gap between rich and poor in terms of hospice deaths actually increased over time. So patients were always slightly more likely to die in a hospice if they lived in a rich area than if they lived in a poorer area. But over time, this gap increased. The inequality there between rich and poor got bigger. Now, several people at the time commented, quite rightly, that this isn't the full story. This doesn't tell us everything about hospice care, about the services we provide. In fact, Ros Taylor wrote, "The socio-economic divide in hospice inpatient units is concerning, but inpatient hospice beds are just a small part of the spectrum of hospice care." And of course, she is right. I would love to know what the socio-economic position of everyone touched by a specialist palliative care team is and how that's changed. But we simply don't have good enough data at the moment to answer that question. And that's where I think the new Public Health England plans for data collection come in. So this is a plan to collect data on everyone seen by specialist palliative care teams, irrespective of the setting, hospital, community, inpatient hospice. And the data collected will include those basic demographic details, but also important information on outcomes, enabling us not only to see who it is we're seeing and treating, but also what the benefit of our treatment is to those patients. So to sum up, I think we need to recognise the limitations of the data we use. Mortality data have been a very valuable resource to us, and we've learned a lot. But it is time to move on from place of death and look at other outcomes, potentially more important or as important to patients and their carers. We need to exploit the data that we already have and is sitting there unused. We need to get smarter at linking data sets to answer those most important questions. And where data doesn't exist and isn't already being collected, we need to start that collection. Yes, the governance required to put this into action is formidable, but I think we can learn from our colleagues in Sweden that it isn't insurmountable. Thank you.
Thank you, Katherine.